So good afternoon, everybody. Salam alaikum. It is my honor to introduce our next speaker, Dr. Elamin Abdelgadir, who's an associate professor of endocrinology at Mohammed bin Rashid University and a consultant endocrinologist at Dubai Hospital. He is a fellow of the American College of Endocrinology, the American College of Physicians, and the Royal College of Physicians of Edinburgh. He's an avid researcher and a very active member of international societies. And he's going to be covering a topic that I'm very passionate about as a metabolic surgeon, which is management of weight recurrence after bariatric surgery and hypoglycemia. Thank you.
Thank you. Assalamu alaikum, everybody. Good afternoon. First of all, I'd like to ask you, please, everyone, buckle up. We're just flying from the sophisticated presentation of the highly scientific and academic presentation of genomics and others down to a very basic and clinically day-to-day encountered medical problem. And I'll try my best to squeeze it down. And before going there, I'd like to thank the organizers for the kind invitation. And thank you, Sarah and Haddad, for giving me two big talks to be squeezed down in 25 to 30 minutes. I'll try to do that. And the intimidation of my chairperson for this session will be a bariatric surgeon. So I have to take hats off to bariatric surgery. I can't say anything against my chair. So I have nothing to disclose, and just to remind you that all the medications that will be presented here and discussed are off-label to be used in post-bariatric hypoglycemia. Starting with the post-bariatric weight regain, it's simply defined pragmatically into any weight regain after a nadir post-operative weight loss. However, it's not that easy. Various professional societies and study groups have put different criteria to define the weight regain after bariatric surgery, whether it's based on the percentage of excess weight loss after reaching the nadir, or using the nadir weight percentage, or using the nadir weight in kilograms. And the definitions were variable from more than 25% of excess weight loss from nadir. So, for example, a patient with 140 kgs, he lost 40%, 40 kilograms, and the nadir is 100, so if he gained 10 or more, this is a weight regain, as per this international society. It looks like an inevitable outcome after we intervene and reduce the weight in people with overweight or obesity. So the mechanism is unfortunately not very well understood so far, but Dr. Acosta have very elegantly alluded to over 40 or 50 genes that we have them that may interfere with weight loss and weight regain, and the melanocortin 4 gene, the mutation is one of the common gene mutation that may hurdle the weight loss and may potentiate higher risk of weight regain after bariatric surgery. Neurohormonal mechanism is the main culprit in that. Psychological and lack of exercise and aftercare are also important. We'll just highlight a couple of them. So the physiological causes, which is basically any psychological or mental status that may interfere with the eating pattern. So depression, anxiety, personality disorders, mental abnormality after bariatric surgery may interfere with the eating behavior and change in the appetite set point and increase the food intake. And this will end up with what's called the loss over control of weight after bariatric surgery, and this will end up with weight regain. The neurohormonal mechanism is a very complicated one. Again, Dr. Acosta have shown a couple of those hormonal mechanisms that interferes with the dynamics of weight maintenance or metabolic and energy balance. So after different sorts of bariatric surgery, we see reduction in ghrelin and increase in the GLP-1 receptor, GLP-1 hormone, PYY, and fibroblast growth factor 19. This is important. We'll come to that in a minute. FGF1 FGF19, CCK, and others. So those are the mechanisms through which we lose weight. So any maladaptation of those might interfere with either the level of weight reduction or interferes with a potential weight regain after some time. And this has been alluded to almost 15 years ago, that the people who responded well to surgical intervention were those who had higher levels of GLP-1 after surgery and higher levels of PYY compared to those who did not do very well in terms of weight reduction after surgery. So the neurohormonal or the hormonal component here plays definitely a role in maintaining the weight reduction or regaining weight. Can we predict that? Again, Dr. Acosta have elegantly alluded to the genetic predisposition and the probability of weight gain. So in general, out of different or various epidemiological studies, that the females are more prone to have regain than males. Youngsters, when we interfere with their obesity at a younger age, they are more prone to have the weight regain, whites more than dark skin, lower BMI at time of intervention, and non-diabetics compared to diabetics. Even diabetics at a lower range of HbA1c, they are more prone to have post-bariatric weight regain. So can we minimize it? We've seen that almost 90% of patients may have some element of weight regain. So our aim here would be to minimize it. I don't think we can prevent it from occurrence. So at least minimize it. So that could be attained by a proper preoperative counseling to the patients, that this could be a problem. Most of us who are seeing the patients with Graves' disease, for example, if a patient is 20 years of age, he's having very high anti-TSH receptor, and he's a smoker, we tend to tell him that you are more likely to have a recurrence if we treated you with antithyroid medications. So why don't we go to the second option or the third option? We don't do that in obesity management, or at least we don't do it enough, that you are a person at high likelihood of having weight regain. That's to say, after intervention, you need to be under closer vigilance to avoid the occurrence of weight regain. So post-operative nutritional and behavioral education is paramount importance. Structural education and physical activity definitely plays a role, and medications. For the time constraints, I've just chosen, this is the meta-analysis that have clearly shown that whoever is enrolled in a structured physical exercise program after bariatric surgery did better in terms of weight regain. So the more structured way of advice in terms of physical activity and follow-up will definitely improve or reduce the probability of weight regain in those patients. And medications. The medications, they do work in pre-surgical status, and they do work in the post-surgical status. There are quite a bunch of pharmacological intervention in post-bariatric surgery, and this particular study of 117 patients who have been initiated on the liraglutide 3 milligrams after 8 years from the bariatric surgery. And whoever enrolled on this study did lose some weight, and the best responders were those who had Roy-and-Y, bariatric surgery, and even sleeve gastrectomy. They lost around 10 kgs after 12 months of liraglutide 3 milligrams. And those with gastric banding did a little bit less than that, but it shows that having the adjunctive therapy of GLP-1 receptor agonists, even after 8 years, managed to reduce the weight in patients post-surgical status. So at the conclusion for the first part of the talk, that weight regain is a variable after bariatric surgery, similar to other modalities of chronic weight management. Some amount of weight regain occurs in almost 90% of patients over the time. Weight regain is multifactorial that needs a thorough assessment and personalized plan as per every single patient. Weight regain should be part of our long-term MDT-based post-operative plan. So shifting gears from weight regain to post-bariatric hypoglycemia. And they've just kept this. This is generated by artificial intelligence, so I just did not copy it from anywhere. I just asked the ChatGPT to draw a glucometer with 54 milligrams. So it's a personalized picture for this talk. So and that's just to highlight that the cutoff point of hypoglycemia in post-bariatric science or clinical practice is 54, not 70. 70 is basically for people with diabetes. For non-diabetic patients, the cutoff points for post-bariatric hypoglycemia as of now is 54 milligrams per deciliter. And again, definition is very straightforward, that post-bariatric hypoglycemia is typically a postprandial hypoglycemia that occurs about 1 to 4 hours after meal, and it's more frequently encountered more than 1 year after surgical intervention. We've done an interesting exercise that we've evaluated the 3 important clinical guidelines in post-bariatric hypoglycemia. This has just been published and it's in press. So it's just sort of comparison. I don't want you to go through the details of it, that the guidelines are very dynamic. We just had a discussion 2 days ago that the guidelines are changing every year in the field of post-bariatric hypoglycemia. So they all agreed that the definition should be having a Whipple triad 1 to 3 or 1 to 4 hours after surgery in someone who have had the surgery more than 1 year backwards. And regarding the blood glucose, again, it was a dynamic process from 50 to 60, probably less than 50, and now we have reached that 54 milligrams per deciliter is the more suitable or cutoff point to deal with such patients. And I just want you to always keep in mind, please, that what we call the post-bariatric surgery syndromes. We have the idiopathic postprandial syndrome, which has been called the reactive hypoglycemia. We have late dumping syndrome, which is the post-bariatric hypoglycemia, and we have the early dumping syndrome, which is a dumping syndrome that we have learned since the medical school. So they may be overlapping, and it's very crucial to differentiate between the early and late dumping. The early dumping syndrome is mostly a vasomotor generated clinical presentation, and usually it takes place in the first hour after having the food. It takes place less than 6 months after bariatric surgery, and it's usually a vasomotor symptoms. That's tachycardia, nausea, GI symptoms, diarrhea, discomfort. Hypoglycemia may present, so we may encounter an overlap between early dumping and late dumping syndrome. And the treatment is completely different. While the late dumping, which is a postprandial hypoglycemia that we are talking about today or concerned about today, is a condition that usually takes place more than 1 year. The hypoglycemia 1 to 4 hours after ingestion of food, and 1 to 3 hours after. It's important to note after the first bite of the meal. Because in the management, we will advise the patients, take your meal over 20 to 30 minutes. So the 1 hour would be after starting the meal or after the latest point of taking the meal. So it should be 1 hour after the first bite of the meal. And it's basically the hypoglycemia symptoms, and it's usually mild to moderate, but please note that it might be severe, life-threatening hypoglycemia. I've seen a patient, one of my patients had a very drastic car accident after an incidence of hypoglycemia, and this is where we discovered that this is a post-bariatric hypoglycemia. So the first presentation of post-bariatric hypoglycemia was in the surgical ICU, unfortunately. So it's usually mild to moderate, but it can be on the other extreme, while the early dumping is usually a very mild symptoms. So I've chosen this picture actually in the first slide and here because when we see this lighting part of the moon, that doesn't mean the rest is not existing, but this is at least what we can see now. So in the pathophysiology of post-bariatric weight regain and post-bariatric hypoglycemia, so far we know only this lighting part. So still lots to be explored and to know about in the near future, hopefully. So the pathophysiology is, again, we don't know much about it. However, we have so many theories that's roaming around these days, and the main culprit is the level of the GLP-1. So we've mentioned, Dr. Acosta, and in previous talks, we've mentioned that the GLP-1 is playing a crucial role in weight reduction. And at the same time, when it goes mad, it has a crucial role in having or potentiating a post-bariatric hypoglycemia. So we have higher levels of GLP-1 in those patients post-bariatric surgery who present with hypoglycemia, and this is basically due to hypertrophy of the L cells in the foregut. So the L cells, the volume of the L cells after bariatric surgery increases by 6 to 20 folds compared to pre-surgical status. This is logically will produce more GLP-1, logically will potentiate more insulin production from the pancreas in response to any ingested food. So, and so many other theories are also playing a role, but the most important one is the high levels of GLP-1 secretion after ingestion of food. And this has been, by chance actually, confirmed that the patients with after Roux-en-Y, they had higher level of GLP-1, higher levels of insulin, and more incidence of hypoglycemia in this particular report. They were preparing the patients for the reversal of surgery. They put a G-tube for feeding, and the level of GLP-1 normalized, level of insulin normalized, and there was no incidences of hypoglycemia in this patient. And when they did the reversal of the surgery, again, that was absolutely physiological levels of GLP-1, insulin, and the post-meal readings of blood glucose. And this has been plotted here, that the red line is at the time of the Roux-en-Y or the gastric bypass surgery. This is the level of the glucose peak after ingestion of food, leading to higher level of insulin, potentiated by higher level of GLP. So the red line is at the time of the gastric bypass, and when they placed the G-tube, the levels of insulin diminished, the level of GLP-1 diminished, and the level of the blood glucose surged after meal, and the reduction of blood glucose has also improved after the G-tube, and it was completely reversed after reversal of surgery. So this confirms in a way that the GLP-1 theory is the main culprit in post-bariatric hypoglycemia. We've mentioned the FGF19 in the mechanism of weight reduction. And again, when they go mad, FGF1, FGF21, and this has been just published a couple of weeks ago, that in people with post-bariatric hypoglycemia, there are higher level of FGF19 and FGF21. So this again might play a role in occurrence of post-bariatric hypoglycemia. Again, Professor Acosta have alluded to what's called metabolomics. Now we are living in the era of omics, metabolome, exosome, exposome, genome, phenome. So the metabolomics are the hormones or enzymes that's being produced in response to any metabolic changes. And all those types of metabolomics have shown higher levels after bariatric surgery intervention. So they may play a role also in the pathophysiology of post-bariatric surgery, and we don't have time to go into that, but this is an area where we will hear a lot about it in the near future. So how do we diagnose the post-bariatric hypoglycemia? It roams around the OGTT, and please do not use OGTT to diagnose post-bariatric hypoglycemia. This is absolutely obsolete nowadays. That's why I crossed it from the start. We have the mixed meal tolerance test, we have the continuous glucose monitoring system, and we have just a simple pragmatic approach to diagnose post-bariatric hypoglycemia. And the pragmatic approach is having Whipple disease 1 hour after surgery in someone who had the surgery 1 year or more ago. And the latest guidelines have suggested to avoid the mixed meal test, and they strongly against the OGTT. And they used or they suggested to use the continuous glucose monitoring as a tool for post-intervention monitoring. And why they suggested the post-intervention monitoring? Because the continuous glucose monitoring have shown a very low readings of blood glucose in people with post-bariatric surgery, so it might give us a false reading or false diagnosis. So as of now, it's not indicated to be an integral part of diagnosis of patients with post-bariatric hypoglycemia. But it's very important to know the pattern of daily, the daily glycemic pattern. So the patient will know that what type of food that induces the hypoglycemia in order to avoid it next day or the days after. So it's good for personalized way of guiding the management after intervention. Thank you very much. So the importance of the CGMS, actually, that was the earlier days. We used to call the post-bariatric hypoglycemia, we used to call it post-gastric bypass hypoglycemia. That was the title, that was the name. Because at that days, even we used to tell patients in the scientific discussions that hypoglycemia occurs only in patients after gastric bypass. But the CGMS, the beauty of it, have shown a tremendous amount of patients with, even after sleeve gastrectomy, they had hypoglycemia as well. However, majority of them, they are asymptomatic, almost 53% were nicotinial and asymptomatic, so that cannot be counted as post-bariatric hypoglycemia. But we had almost 40% of patients after sleeve gastrectomy having a post-bariatric hypoglycemia. So it's not only after gastric bypass, it could be also after sleeve gastrectomy. Management, in a very short words, it's a very huge area to cover, but it's basically through dietary modification, a little bit of pharmacological intervention, and sorry for the chair and the chair of the scientific committee and the chair of the session, the surgery is the least to go for in terms of management of post-bariatric hypoglycemia. However, it might be needed at some point in time. And for the sake of the time, I just omitted the previous guidelines. The dietary modification is simple. Avoid direct carbohydrates, avoid sugar, choose complex carbohydrates, higher protein level, and reasonable fat level. Avoid alcohol. In other guidelines, avoid caffeine as well. However, there is a little bit of variation in the data. So in general, you can avoid caffeine until we get further confirmation. Pharmacological management is still, as I mentioned earlier, they are all off-label, no FDA-approved medication to treat post-bariatric hypoglycemia. We have some with a backup of proven clinical trials. We have some based only on case reports. Those with proven clinical trials are the acarbose, somatostatin analogs like octreotide and pasireotide, and some of SGLT2s, canagliflozin and empagliflozin. We have the historic intervention, the calcium channel blockers. I don't think anyone is using them now for post-bariatric hypoglycemia, verapamil and nifedipine. Diazoxide is frequently used for refractory cases. Liraglutide has also a backup of some case reports. We have a promising medication that's in the pipeline, that's the GLP-1 antagonist, and have shown tremendous results in the phase 2 clinical trials, and we expect that to come to clinical practice soon. We have the glucagon pump, we have the insulin receptor modulators, and the interleukin-1 blockers. So, and last but not least, in intractable cases where when they are refractory to dietary modification, medical management, we can go for surgical intervention and that's not frequently encountered. So with that, Mr. Chairman, dear colleagues and friends, please allow me to conclude that post-bariatric hypoglycemia per se is a very common encounter after bariatric surgery, Roux-en-Y and sleeve gastrectomy. Symptomatic hypoglycemia is a core for diagnosis of post-bariatric hypoglycemia. Pathophysiology is not fully understood. However, the GLP-1 is the main culprit. A pragmatic approach of diagnosis is recommended. please do not use OGTT for diagnosis of post-bariatric hypoglycemia, and use the mixed meal test with caution. Continuous glucose monitoring is a good tool for post-operative treatment monitoring. Dietary modification is always the first-line therapy, and it cures almost 70% of cases. Acarbose, octreotide, pasireotide, and diazoxide are helpful whenever needed. Newer agents are on track. And with that, I'd like to thank you very much and happy to answer any questions.
Thank you very much for that great talk, and I think we have a couple of minutes for some questions.
Thank you, Dr. Abdelgadir, for your nice talk. Actually, you have mentioned hypoglycemia after surgery due to GLP-1 increase. Actually, we have used GLP-1 agonist, especially Mounjaro, and has been marvelous results with such treatment. So how would you comment on that?
Yeah, that's a very important question, and I expected it will come. The answer for this is not very well understood. Again, however, the theory is a continuous stimulation of GLP receptors might down-regulate it. So the theory behind that, you are giving a supraphysiologic level of GLP-1, so it overstimulates the receptors, and we have in the back days in the physiology that down-regulation, when you overstimulate any receptor, it may go into down-regulation. So this is the theory so far for using the GLP-1 receptor agonist, and yes, we have all used different types of GLP-1 in post-bariatric hypoglycemia patients with a variable response. But at least theoretically, but this is not backed up with the clinical trials or at least prolonged case series. But yeah, we can use it in particular patients that at least as per the latest guidelines, it's not one of the highly recommended agents for post-bariatric hypoglycemia.
Yeah, just a few comments. On the weight regain, we stopped using the word regain because that implements that they're guilty of it. So we would like to use the word recurrence. So WR still stands.
Okay.
The issue of the hypoglycemia, the 1 hour differentiation between early and late, I'll tell you from experience, most of our bariatric patients, the bypass patients, have a much earlier, and it is hypoglycemia as well. And the reason is because there's unopposed absorption of glucose in the raw limb. And in fact, this is one of the differentiating points. We see patients who have postprandial, they're easy to manage, but the patients who have hypoglycemia when they don't eat, that is the patients whom you need to refer to surgery sometimes. They have more like an acidoblastosis form of hyperinsulinemia. And those are the patients where we reverse them to normal anatomy and we help them, or we reverse them to a sleeve. And we have a bunch of these patients. And in fact, you would see, like you mentioned, in bypass and sleeve, you see these phenomena. And the experience for us is now calcium channel blockers than the GLP-1 agonist, where we blunt that upraise, because it's basically insulin secretion has changed from this slope to this slope with food.
Thank you very much. That's a very valuable point. Actually, the 1 hour cutoff point and the 1 year cutoff point has always been an area of debate. Why have we chosen the 1 hour and the 1 year for post-bariatric hypoglycemia? Actually, this is based on mechanistic studies where they monitored the slope, the upslope of GLP-1 and the upslope of the insulin after bariatric surgery, in those cases. And it has been consistently shown that those higher level of GLP and the insulin, the peak usually reaches between 1 to 2 hours after ingestion of food. That's why, as per definition, it's more than 1 hour. However, the overlap has always been encountered in many cases. It's good to treat both of them, it's fine, but as of now, the definition is more than 1 hour and after 1 year of intervention.
Yes. I think we have time for one more quick question.
With the high percentage of people regain weight after bariatric surgery, do you think that we need to advocate like a new guidelines for those who are kind of fit the criteria for bariatric surgery, but they need to go first through the pharmacology treatment prior, like referring them to the surgeons? Because now we are seeing these days in clinical practice, many patients who post-bariatric surgery or bariatric surgeons refer them to endocrinologists or family medicine doctors to start treatment on GLP-1. But do you think this is time to consider the guidelines in terms of referring them to surgeons first, give them an option, starting them on pharmacotherapy rather than referring them to the bariatric surgery? I'm sure the bariatric surgeons will kill us for this.
And the chair of my session is bariatric surgeon, but sorry, Mr. Chairman, but this is already happening. This has happened already, has been endorsed by different guidelines that the surgically sparing or surgery sparing agents are the newer forms of GLP-1 receptor agonists. They maintain a level of weight reduction comparable to sleeve gastrectomy, and in some cases comparable to gastric bypass. So, and this has already been practiced, that before sending the patients to bariatric surgery, now the interim of using the GLP-1 receptor agonist, as of now, is becoming a common practice. And this has been backed up by the clinical guidelines. Depends on the availability, definitely, of the medication, of course.
Thank you very much.